This is chapter 12, Spirituality and Religion. Why do we assess religion and spirituality? Well, at the most basic level, we want to know our patients, know our whole patient. And nursing theories, all the nursing theories I'm aware of, treat the person as being mind, body, spirit. I don't know of any strictly materialistic nursing theories of the person. Patients may also have religious restrictions on many things. There probably anything you can think of at some time in history, somewhere there's been a religious restriction on it. But some of the more common ones are diet, activity, and social contacts. And religion and spirituality are important for social support, but that's kind of a mixed thing because they also are instruments of social control. And just as they can be helpful, they can be harmful too. People tend to turn to religion and spirituality in times of stress. Not always. Maybe they turn away from them too. But they do tend to turn toward them. And in many philosophical systems, and certainly in nursing theory, spirituality is closely related to the person and to health. Some of the coping mechanisms in spirituality and religion are prayer and meditation, and those can be either at set times, prescribed times, or they can be informal when you feel like it. And sometimes patients may have objects that are particularly meaningful. Be sure to treat those objects with respect. If you come in and you say, oh, I'm going to need this bedside table to do a Foley, don't just pick up the objects and move them willy-nilly. Tell the person, ask the person, where would you like me to put this, and show some respect. Also, it's fairly common for the patient to receive visitors from religious organizations. If you think about it, who is going to visit you when you're in the hospital besides your family? In many cases, it's people from the religious organizations. In the book, it gives us two circles that intersect in a Venn diagram where there's one area for religion, one area for spirituality, and then a fairly large area that's shared between the two. But generally speaking, religion is going to be more formal and spirituality is going to be more personal, more difficult to measure or define. Where if you think about it, if I wanted to know how religious a person is, I could observe that person for, say, a week and see all the things they do and maybe note how much time they spent doing various things, and I could probably get a good measurement of how religious they were. But that probably wouldn't help very much with spirituality. There are ways to measure spirituality, but we're probably going to be more relying on self-report. With religion, in a sense, it doesn't, and the religious people would dispute this, but in a sense it doesn't matter whether you really, what your inner attitude is. I mean, they would say it matters, but a lot of times you'll find people that will go to religious organizations that don't necessarily fully believe in it, and they may go for social reasons or other reasons. So those are some of the similarities and differences. But there is, like I say, a large area of overlap where that religion and spirituality are both involved. As far as evidence-based practice, there have been some studies that relate spiritual practices to better health. And then there's also the case that some of the restrictions that religious organizations impose may improve your health. Like they may restrict tobacco, alcohol, and that kind of thing. And certainly that would probably be good for people's health if they follow those kind of restrictions. So there are many religions that forbid pork, and some may forbid meat entirely. Some people that aren't religious but are spiritual may have issues with eating meat because if you think about it, frankly speaking, it is killing animals, and if you have any feeling for animals, why maybe it bothers you about eating meat. For most of us, it doesn't bother us enough to stop doing it, but I think a lot of us are actually bothered if we think about it, that, well, this meat that we're eating was a living animal that had to be killed. And then there may also have rules about fasting during certain days. They may have rules about resting from work, and so that could, like, some people may say, well, work, as long as I'm not getting paid for it, I can go out and work on my car or fix my car or do my gardening or whatever I want to do. Other people, oh no, you can't do those things. So there may be some patients that wouldn't want to do certain tests or medical procedures on the days that they're supposed to rest. And then there can be rules about what parts of the body you can show. Not always parts that you would think. Maybe restrictions on parts that to you would think, well, why do they care about that part? But and then there may be some rigidly prescribed gender roles, and this probably is the issue that causes the most, or it causes a lot of moral problems for the nurse, because maybe we have, say, a woman that's, oh, well, I have to ask my husband, he makes the decisions, and we want to say, oh, this is the 21st century, how could you let a man make all your decisions like that? And then you find out that her whole community is like that, and in some sense she buys into it, and then that is kind of puts you in this bind of, well, she's being abused, and maybe in some ways she is, but on the other hand, it's her culture and her choice. How free is her choice? Well, that's kind of a difficult question to answer. Now, different religions will inculcate or encourage attitudes toward things, and they don't always just explicitly, it's not always part of the program that they mention, but sometimes these things are transmitted unconsciously. But there can be different attitudes towards suffering, like, is suffering punishment for sin, or is it just an unfortunate thing that happens that we should try to relieve as much as possible, or is it a sacrifice we make? Again, the body, is the body a temple, or is the body something that disturbs us because it's a prison for the spirit? Or is the body something shameful that represents our lower nature? What is the meaning of life and death? Is there life after death? And if there is, what is it like? What kind of things happen there? What kind of life is it? Is there a meaning to illness? And then human nature, again, what is human nature? What is our place in the universe? So, to start, you need a working knowledge of common beliefs and practices in the community, but you have to take a certain amount of humility there, because your patient is not going to perfectly represent those common beliefs and practices. So you always have to be aware of individual differences too. And how people relate to their stated religion is highly variable. Like some people, if you ask them their religion, they put down something that they were raised in but they haven't really thought of for many years. Other people may be changed from that original religion to something else. Other people put something down, but they're kind of very much at odds with it. So, or other people maybe put it in one compartment of their lives and then the rest of their life is in another compartment. And we have to be aware that religion and spirituality can have negative impacts too. For example, they can delay you in seeking care if you think, well, I'm just going to pray, or I'm going to wait for a miracle, or this and that. They can even make you refuse needed treatment. If the person is an adult, we have a duty to inform them of what might happen and what the alternatives are, what the risks and benefits are, and make sure that they have been informed, document that, and then all we would need to do is just notify the physician, notify your supervisor. So it's their choice and they're a competent adult. But if it involves children, a lot of times the hospital will involve CPS, and that puts us in an adversary relationship with the parent, and that's not good for anybody involved. It becomes a very difficult situation. Other negative impacts, sometimes religion and spirituality can cause you to have depression or anxiety about things that to everyone else well, that's ridiculous to be anxious or guilty about those things, but it's very real for the person involved. So how do we incorporate religion and spirituality in our care? Well, for one thing, you may be asked for spiritual or religious assistance. Maybe the person asks you to pray for them. Maybe you're working OB and there's a baby born that will only last for a few minutes and is breathing but can't really be said to be alive, and it's basically a DNR situation with the baby, but the baby's still breathing, and the mother asks, could you please baptize my baby? And you don't believe in baptism. And she says, well, that doesn't matter. My priest says any person can baptize. All you have to do is pour water and say the words. And if you are comfortable with it, you can certainly do it. But if you're not, then you should try to find someone that can do it for them. You can't always, maybe you won't be able to, but you could make an effort to try and find somebody that can help her. As I say, I think all the nursing theories I'm aware of include spirit in their description of the person. And so maybe you're saying, well, that's really a problem because I don't actually believe in spirit. I think that matter is the only thing there is. And so don't give up. You can still be a nurse. It's just when you need to use theory, you're going to have to either develop your own nursing theory, which is probably quite a bit of work, or you can borrow a theory of the person from some other science, such as maybe psychology or biology. And spirituality is addressed in the Nanda diagnoses, as we'll see a little later. A lot of times we're going to be doing referrals, and the most logical person on the hospital staff would be the chaplain. Now, the chaplain is whatever religion she or he is, uh, but they will have lots of resources available so that if they can't help the person, they will have community resources they can call on to help. So self-awareness is extremely important, and it's frankly it's uncomfortable sometimes. Maybe you have been avoiding these kind of questions and been quite happy to be avoiding them, and now suddenly you're being thrust into asking some questions about yourself that aren't that comfortable. Like maybe you start, when I say what do I think about the relationship between spirituality and health, and maybe you have some glib answer that you've been taught that sounds like a nice socially acceptable answer, like oh well, prayer helps the sick and it's good for health, and you think, as you say it, you think, well, I really don't believe that. And maybe that's kind of uncomfortable, and you think then the next question is, well, what do I believe? And it's like, oh, I would really rather avoid these questions, but well, relax. You aren't going to finish this in one day, and you aren't even going to finish it in 1 year. And it will change. Wherever you are now, 5 years from now, you'll be somewhere else. How would I respond to a request for spiritual assistance? Just like with anything else in nursing, you should probably think about what may occur and try to be prepared. Does it always work? No. Sometimes patients throw you things that just totally throw you off kilter. But thinking about it ahead is an advantage. So, spiritual assessment may be part of the initial assessment, or it may be ongoing. A lot of times in the initial assessment, we maybe just get their religious preference or religious background, and if they wanted someone notified, or if they felt like there was some restriction that would be like such as diet or resting on a certain day or things of that nature. But you may also have an ongoing assessment when you discover that the person is having some spiritual issues, and so that assessment would be like more than just that initial assessment. That would be the ongoing assessment. A lot of times you'll have a religious affiliation before the patient even comes to the floor, because the admitting clerk asks and puts something down. But for example, I had one patient when I asked, and he said, oh, I'm nothing. And then he thought about it, and a minute later he said, oh, don't put down that I'm nothing. I had already put it down, but obviously I can go back and change it. He said, don't put down that. Put down I'm Baptist, because I don't want people to think I'm just some total heathen. And so I put down Baptist. And I later got to know him, and it turned out that he had been raised Baptist and was very strongly into it for a while, and then at some point he left it. But even so, a lot of aspects of his personality were shaped by that. A lot of his values and reactions and outlook on life was still shaped by that religion. So it was that I could understand why and how, why I did put that down that way. The client's, and then this next statement here, the client's relationship to her or his identification may be more important than what they actually are. And I think that's so true. People with different religious backgrounds can sometimes be very close to each other on the level of spirituality. And then people of the same religious background can be very different from each other on the level of spirituality. Like, for example, the Quaker religion, it's not very popular here, but I think in the East and in history, American history, it was pretty important. Richard Nixon, President Nixon, was a Quaker, but the Quaker religion really focuses on peace and all that, and Nixon was kind of a warlike president. And so some Quakers just didn't identify with Nixon at all, and Nixon probably didn't identify with them either. The client is the focus. So as a nurse, whether or not you're a spiritual person you can still do good spiritual assessments, or whether or not the client is the same type of spirituality as yourself, it doesn't matter. You can still do good spiritual assessments. And by the way, maybe you say, well, my religion says I have to go out and try to convert everybody because that's what I'm here for. And that's fine on the outside, but don't bring that to the hospital, because basically if you do that in the hospital, you're committing a boundary violation. You have these people they're a captive audience in a vulnerable relation to you. So it would be unethical to try and impose your religious and spiritual views on this captive audience when they're in this vulnerable condition. And we want to identify what it is that gives the client strength. So one of the informal approaches uses this SPIRIT acronym, and it looks at belief system, their personal spirituality, community, rituals and practices, care, and their terminal events. More formal approaches would be written questionnaires or scales. Those are probably more used in nursing research than in actual practice, but you might have occasion to use a tool like this in practice too. So some of the things we would look at in a thoroughgoing spiritual assessment, which is probably not what you would do routinely, but if you really needed to explore it thoroughly, you'd look at their background, verbal and nonverbal communication when they discuss these things. What support systems do they have? Are they now involved in a formal way in religious organizations? And what personal importance does it have to them? And what are their support systems? And then stressful relationships. Remember, I said earlier, we have all this great social support, but we also, a lot of times that comes with social control. And these people, all these nice people that come from your church that are supporting you, they're also kind of policing your behavior. Most everyone, I think, that has any kind of religious affiliation probably disagrees with it on something. My aunt says she has never belonged to any organization that she agreed with 100%. And I think most of us, unless you're just a blind follower, you're probably going to have some disagreements. What aspects and practices do you find most helpful? And how has illness affected all of this? Are there some potential conflicts? If there are, then you're going to need to notify the provider and probably your supervisor to give them a heads up that there may be some problems, ethical problems coming ahead. Would it be helpful for the person to speak with somebody, and who would that be? That's not always the person you would think. I had a patient that was a Baptist, but this was a Catholic hospital I was working in, so all the chaplains were Catholics. And so the Catholic chaplain had gone in to see him, and I came in a little later, and he says, "Oh, the chaplain was just in to see me. She was so nice." And I'm Baptist myself, but she was a lot more friendly and nicer to talk to than a Baptist preacher. So I guess he got what he needed from her, and so I probably wouldn't call the Baptist preacher for him unless he asked me to. Specific practices that may impact care. For example, if some traditions you have to be in certain positions to pray, or some, like in yoga practices or meditation practices, maybe you are supposed to be in a certain bodily position. Well, how does that work if you have orthopedic surgery? And then how can we support you? So, diagnoses that we have. And then we have a couple health promotion diagnoses here. Readiness for enhanced spiritual well-being. This is probably the person that says, well, you know, this illness has really been a blessing for me because it brought me face to face with what's really important in my life. That might be that person. Or readiness for enhanced hope, something very similar. Now, we could have spiritual distress as an actual diagnosis, but we can also have risk for spiritual distress. Likewise, risk for loneliness and risk for social isolation. For example, some religions, that social control thing again, some religions, if you stray too far, they'll expel you from the group. And if it's a tight-knit group that you've been close to for your whole life, that can be devastating when you lose all that. And if they expel you from the group, and maybe they tell the other people in the group, don't talk to her, she's expelled from our group and she's a bad person, and so don't even talk to her. Then spiritual distress and hopelessness. Moral distress is usually a situation where you've got two conflicting values. Like you want to, maybe there's two things that are right, then they're in conflict, or maybe you feel like you're being forced to do something that you believe is wrong. Like going back to that woman that looks to her husband for everything, and we think there's some abuse here, but then she's consenting to it. What do we do? Then the nurses in that case are in moral distress. And so certainly that, going back to that idea of self-awareness, when you feel a conflict of that nature, why then look to your own sources of strength and resources and try to resolve that, because until you resolve your own conflicts, you'll not be able to help your patients with theirs. Well, that's all for this lecture, and thank you.